Hello. Many imaging modalities are utilized to evaluate patients with suspected COVID-19, and we will be talking about lung ultrasound. We will be talking about imaging and findings, and I will be demonstrating through the use of a BodyWorks Eve simulator. I'm John Shields. I'm a nurse anesthetist and faculty at Middle Tennessee School of Anesthesia. As well, I'm on staff at Vanderbilt University Medical Center. Diagnosis and complications of COVID-19 we're all becoming very familiar with. Pretty much diagnosis is now limited to the RT-PCR, which is supposedly the definitive diagnosis. It's very specific, but it has a pretty low sensitivity, or relatively low sensitivity, about 60 to 70%, so you could have a very large number of false negatives. Other lab findings include lymphopenia, increased PTT, and increased lactate hydrogenase. The radiologic exams available to us in order of specificity and sensitivity are CT, lung ultrasound, and chest x-ray. However, I believe that you shouldn't probably be using any of these in and of itself. You should be using it in addition to whatever else you have as far as assessment goes. Chest x-ray is pretty low, way down there because of all the other rule outs. It's around 18% or so. And as we all know, the complications include ARDS. Acute cardiac injury is becoming something that's talked about a lot as well. Secondary infections, sepsis, and multi-organ failure. Some of the imaging strategies with lung ultrasound, there are 4 chest areas per hemithorax for a complete 8-zone lung scan. Some go as high as 12 and 16, which include the posterior regions of the chest. Areas 1 and 2, as you can kind of see here, are the upper and lower anterior chest areas. 3 and 4 are the upper lateral and basal lateral chest areas. And we'll be talking about each one of these areas as we talk about some of the findings with COVID-19. The parasternal line is the border for areas 1 and 2. And of course, when you get into the sternum, you start to have a lot of dropout. The anterior axillary line is the border between areas 1, 3, and 2 and 4. This is the pretty much the upper and the lower regions. And then the posterior axillary line marks the border for areas 3 and 4 in the beginning of the posterior chest. So in looking at these different regions, it's kind of good to know, because we'll be talking about these different regions as we go over some of the findings and some of the actual ultrasound scans that you would find. So not to go too much into the basics of ultrasound, but just for some of those that are naive, lung ultrasound relies not only on the direct visualization, but also interpretation of lung artifacts. Air, of course, does not reflect very well, but you get some interesting artifacts which kind of tell you a lot about what's going on. Typically, you have some very normal findings, such as A-lines, and you also have sliding along the visceral and parietal pleura. This is where your transducer is going to be. This is a curvilinear transducer, of course. Some of the physical finding that you can actually see along with the sliding phenomenon is pleural effusion, a very anechoic region in the chest. You also see some consolidation as the alveoli become filled with fluid, blood, or whatever. You get some consolidation or pneumonia, which gives it more of an organ type appearance. And also, pulmonary edema and interstitial disease can be evaluated, but typically through things like B-lines. Curvilinear is considered the best all-around probe, but the phased array is also used, especially from some of us that use a lot of scanning for cardiac. A comprehensive POCUS scan can actually be done in 5 minutes using this technique, using the 4 zones on each side, 8 to 16, whoever you read. And typically you have better diagnostic capabilities with lung ultrasound than physical exam and chest x-ray combined. So as you can see here, as the lung moves, you get sliding right along the pleural line here. The different A lines are just the normal reverberations as the ultrasound kind of bounces along down through the alveoli, and then the returning signal is converted from sound waves back into energy and an image. Then you can also see some dropout here from this rib shadow, which is pretty standard. Lung ultrasound in the diagnosis of acute respiratory failure has been talked about a lot with Lichtenstein and his colleagues in chest about 12 years ago. Lung ultrasound's been around actually since about 1993, 1994, especially in the emergency department. But you're evaluating 4 basic assessments, which are the lung artifacts we talked about, the A and B lines, sliding, which is giving you a good idea about pneumothorax and some other issues, and pleural effusion, which is basically an anechoic region in the subphrenic area right above the diaphragm, which we'll show you and demonstrate in a moment. Blue protocol was talked about in this chest article, and you're talking about first evaluating lung sliding, then if they're present or absent, you go down a different pathway of looking at A and B lines, ruling out pneumonia, and you can even go into PE using some other point of care ultrasound techniques. So let's talk just a little bit about B lines. B lines basically are the alveoli that are filled with fluid or some type of interstitial disease, and typically in this patient with congestive heart failure, you can see you've got a lot of B lines, fluid-filled alveoli. You've got a pleural line here that you do have some sliding, and you've got your rib shadow. In contrast, you have pneumothorax here on your right. You can see some sliding over here right around this lung point, but you have no sliding over here, which tells you that you actually aren't really moving a lot of that lung. You do have some A lines here from the normal reverberation from the transducer, which is on the chest wall. If you're looking at pneumothorax and you're trying to evaluate that along with your standard 2D scanning or B mode, you can also use M mode, which is where you basically put the transducer on the chest wall and you're getting a slice through this 2D image here. So what you've got is you've got the parietal pleura and the visceral pleura. You've got the pleural line here, and you've got an ocean effect because you basically have no real movement in the parietal pleura, but across the pleural line and the visceral pleura, you do have lung movement. You can kind of see the lung going up and down. So you have an ocean effect, which is pretty much stable visual, and then you've got a sandy beach, which is rather speckled, and you've got some A lines interspersed in there. Now, as opposed to normal lung, pneumothorax, you've got the typical parietal pleural, the ocean, as you can see, just like you do in normal lung, but you have barcode instead of sandy beach because nothing's really moving. It's all very stable, very consistent pattern. So if you're looking at normal lung versus consolidation, you can see on the left you've got the typical pattern. You've got sliding, you've got nice A lines, you've got the rib dropout, the rib shadows, and over here on the right you've got some consolidation. This is where your curvilinear transducer is, this is where your pleural line is, this is where you've got some nice sliding, but at the same time you've got instead of just the usual non-reflective pattern with A lines, you've got consolidation, so the lung is starting to look a little bit more like an organ. Side of pneumonia, there's a lot of different things that you've got to rule out, bilateral versus unilateral, etc. Then if you're looking at consolidation versus effusion, normal lung, you've got this is actually in the right basal lateral or the right upper quadrant imaging. You've got the probe way down in the right lateral base position. So you've got lung here, you've got diaphragm, and you've got liver. And typically you're going to have the image, the sound wave is going to bounce off the diaphragm into the liver into the lung, which is not going to reflect anything, and then the mirror is going to have some image, you're going to have some mirror artifact to the liver that's going to go transmit back up to the transducer, and you're going to get this mirror artifact. If you have a pleural effusion, typically you've got the diaphragm, which you can't see too well here, but you've got this anechoic region here of effusion, and you've got the liver here, diaphragm, and you have no mirror artifact because this is filled with fluid, so it's really not going to bounce your liver image back up to your probe. So you've got effusion, you've got consolidation, and then you've got normal lung here where you've got a mirror artifact. So let's talk a little bit about COVID-19 clinical presentation. Non-specific or even asymptomatic presentation in a lot of people. Fever is probably the most common symptom. A dry cough, fatigue, sputum, shortness of breath. There's a lot of other little symptoms that are much less common, but I'm not going to discuss anything that is less than 15%. Unfortunately, the chest x-ray is very nonspecific. This is your typical COVID-19 chest x-ray, and this looks a lot like another 10 or 12 presentations. But typically you have an atypical or organizing pneumonia with bilateral peripheral basal distribution with extensive bilateral ground glass opacities, especially showing up on CT. So if you're looking at CT versus ultrasound, and if you're working in a busy ER, or if you don't really have access to CT, or if you just are swamped like a lot of places are right now, CT is of course much better than ultrasound, but ultrasound, especially point of care ultrasound, is very, very convenient, and you can often make in combination with a physical exam and presentation a good diagnosis. But CT, you're going to have thickened pleura, ground glass opacities, or the crazy paved road. You're going to have pulmonary infiltrating shadow, subpleural and airspace consolidation, and a host of other things that show up on CT, which again are not as specific as we'd like. And on ultrasound, you have thickening of the pleural lines with pleural line irregularity and subpleural consolidation, which we'll see in a moment. Multiple B lines in a variety of patterns, and often very confluent with skip lines where you're kind of skipping a lot. Rare pleural effusions, you just don't see that a lot with COVID-19. And you're going to have consolidations in a variety of patterns, including multifocal, small non-translobar, and translobar with occasional mobile air bronchograms, which we'll see momentarily. So this is a normal scan. You've got in a patient that is the first case that we'll discuss over here, as you can see in the right panel. Their room air sats 98%, good blood pressure, slightly febrile, but you got a nice thin pleural line. You've got nice A lines. There's no B lines, no consolidation. This is an upper anterior scan. So this is in region 1 of the different regions and areas that we talked about. Moving along to a different patient. This is a patient that is presenting with a room air sat of 94%. Your blood pressure is normal, but you do have a little bit of a temp, 100.2, with some breathlessness. And what you can notice from this upper anterior scan, which is in region 1, you get a little bit of a thickened and irregular pleural line here with an increased number of B lines, and you have areas where you have no A lines at all. You do have some A lines in here, but in general you have some regions over here and over here that don't really have a lot of A lines. So this is a patient that you're getting a little bit suspicious for this presentation. This is the same patient. This is the right basolateral. Again, you've got this irregular thickened pleural line. You've got some more B lines coming in here. Again, you don't have that many B lines, but you've got you're dropping your A lines out, but you do have some A lines. So it's not really definitive, especially with this rib shadowing that you've got over here. And in this patient, you're starting to get pretty hot. You're about 101.3 degrees, 90% on your room air sat, a little faster respiratory rate, and now you're getting periods of agitation and a persistent dry cough. Your pleural lines become even more thickened, a little bit more irregular. It's very diffused and thick. You've got a complete absence of A lines now. It's just a preponderance of B lines, which are visible throughout all lung zones, all 8 to 16, and you also have a little bit of consolidation, which we'll see momentarily in the bases. Again, this is a patient that's a little bit further along, and you're really starting to get suspicious for some type of COVID-19 presentation. This is the same patient. You've got a right basolateral scan. You've got the pleural line here with some rib shadowing with a lot more B lines. Again, you're starting to see everywhere you look, you're starting to see a lot of B lines. And this is a bilateral thing. It's not just unilateral. And this is the right base, or around the right upper quadrant. I really like this view because it gives me a nice view for several things, including to rule out infusion. But in this particular patient, you've got a liver here, you've got the lung, you've got a lot of B lines here. You can't see the diaphragm very much because the B lines are so thick and confluent. You've got a little bit of a consolidation here. It's probably 2.5 centimeters or so, measuring caudal to cephalad. So you're starting to really become suspicious with the thickened pleural line, with consolidations, with no effusion for some type of COVID-19 patient. And in this patient, you've come to the point where you're having to intubate. Your SAT's very, very low. Blood pressure's down. You're getting tachycardic. You're intubated in 102 degrees. You got a lot of sputum. You're having rigors. You're having all sorts of pulmonary issues. The upper anterior scanner in region 1, you can this is where your ultrasound probe is going to be. Very thick pleural line. You got the rib shadow, and between the rib shadows, you've got just nothing but B lines, just very hazy. If you have an older television, you've got some type of static interference with it. This is in the right basal region, probably around area 4. Again, there's the pleural line. You also happen to have some consolidation, and in this consolidation, it's a very large area of consolidation. You're surrounded by B lines. You're pretty much have static bronchogram is what you've got. Not a lot of stuff is coming in and out of there. It's just some nasty, junky stuff. And this is in the bases. This is pretty much what you're going to see. And this is in the right base, around the right upper quadrant. Again, the confluence of B lines. The pleural line is very thick, and you're getting some subpleural consolidation, similar to what you would see on a CT scan in patients with COVID-19. So scanning from the left anterior chest down toward the spleen, you see a lot of B lines, you see the rib shadows, you see a thickened pleural line. You make your way down to the subphrenic region, to the diaphragm. You see spleen. You don't see an effusion there, but you see a lot of B lines. Then if you move up cephalad toward the right anterior chest, you see those same B lines, very thick pleural lining there. And as well, you can start to see a little bit of consolidation here around the lateral base. And then when you get down to the right upper quadrant, you see that subcostal consolidation there. So the conundrum here, obviously, is that there's a lot of other rule-outs that you have to go through in the patient with COVID-19, given the presentation. Viral pneumonia, influenza, CMV, SARS, bacterial pneumonia, pulmonary edema, interstitial lung disease, and then COVID-19. So the initial evaluation occurs where you have to do a chest x-ray, lung ultrasound, maybe a trip to the CT scan if you think it would affect the management, maybe even no imaging at all, depending on what you find. So it's a very difficult pathway to get. So a lot of what the decision making comes down to is what you're comfortable with and what you're going to find with ultrasound. So these are some references I've got. If you like to get a little bit of a more practical approach to lung ultrasound, Miller's got a very nice paper here. Lichtenstein and Mazer talked about the Blue Protocol and diagnosis of acute respiratory failure, and Volpicelli and his group had a very nice treatise on the evidence-based recommendations for point-of-care ultrasound. Thank you very much.